Thank you, everyone, for your patience and for your continued attention. It is now 3 minutes after the hour. We're reconvening the ACIP meeting to begin oral public comment. I'd like to welcome and thank our public comment speakers today for addressing the committee. All the speakers submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we do have a limited public comment period, and in order to make it through all of the listed speakers, it's extremely important each speaker limits his, her, or their remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. And as a gentle reminder, our committee appreciates the diverse viewpoints that are respectful in nature and focused on the issues being discussed at our meeting today. And thank you again to our speakers. We look forward to your comments. The first public comment speaker is Donna Trubig.
Hello, can you hear me?
We can, please go ahead.
Thank you. Hello, I am a licensed childcare owner provider. I have worked very hard over the last 3 years and continue to work to protect the very young children I care for, including my young grandchildren from this virus. I have no conflicts. I'm also a proud member of Protect Their Future, a nonprofit grassroots advocacy organization made up of parents, doctors, and scientists dedicated to ensuring that children are prioritized regarding the development of vaccines. While I am a member, the following comments are my opinions. Our children need your commitment to the early approval of the next round of fall vaccines before school starts in August. We need all children, including children under 5, to be vaccinated and have immunity before starting school and daycare this fall. Please simplify the process. Families across the country are actively looking to vaccinate their young children, but pharmacies will not administer them, and pediatric offices cannot manage a large stock of vials. All vaccine trials and next generation solutions should include all age groups simultaneously. We know that the vaccines are safe and effective. We also know from the data that children under 1 are at a higher risk for COVID complications. Babies cannot wear a mask to protect themselves. Even based on today's discussion, please do not continue to leave them behind. It would be beneficial for those who haven't been infected, pregnant women, people with high BMI, and others to have access to another bivalent booster before the late summer spike. There shouldn't be an age range immunocompromised requirement to get a second bivalent booster today. It is too early to move to a once-a-year flu shot type schedule for COVID. COVID is still mutating. The vaccine manufacturers need to be ready and free to produce a variant-specific booster that is quickly available to all age groups. Thank you very much.
Thank you very much for your comment. Our next public commenter is Ms. Crescent Martin.
Hi, can you hear me?
We can, please go ahead.
Good afternoon, and thank you for the chance to comment today. I urge the ACIP and CDC, in coordination with colleagues at FDA as needed, to immediately grant pregnant people permissive access to an additional COVID booster based on their pregnancy status. Recently, the WHO updated its recommendations to include pregnant people as a high priority group and to recommend that pregnant people receive an additional booster dose if their last dose was more than 6 months ago. I was heartened to hear Dr. Sarah Oliver state at the February ACIP meeting that a deeper dive into the emerging data on vaccination among pregnant individuals, with a view towards assessing what data is needed to make recommendations for that population, is among CDC's top priorities for upcoming meetings. But I'm here to remind you that people who are currently pregnant do not have the luxury of waiting for a full consideration of all of the emerging data. I received a bivalent booster as soon as I could get an appointment in September, more than 7 months ago. I'm currently in my 3rd trimester of pregnancy, and I recently received a Tdap booster as recommended to protect my infant against whooping cough. However, under current restrictive US authorizations, I'm not eligible to receive an additional COVID booster to maximize the maternal antibodies I could be passing on to my infant. These antibodies could help reduce her risk of serious COVID complications before she is eligible for her own vaccination. For context, this is my second pandemic pregnancy. My first pandemic baby was born in summer 2020, a truly scary time to be pregnant before any vaccines were available. My family tried hard to shield my son from getting COVID until after he was finally eligible to be vaccinated in June 2022. In large part, our concerns were about the unknown long-term consequences of infection with a novel pathogen, especially with a naive immune system. In 2023, we are now fortunate to have the tools of vaccination, and so it should be much easier to protect this pandemic baby. However, the current move to an annual vaccination schedule does not have enough flexibility to optimally protect the vulnerable groups of pregnant people and infants under 6 months. As we wait for sufficient evidence to support an affirmative policy recommendation that a COVID booster is absolutely necessary in each pregnancy, we do have very strong safety data. The currently available evidence suggests that the known and potential benefits of an additional booster are likely much higher than the known and potential risks. It would be a reasonable choice under a shared clinical decision-making model for a pregnant person to choose an additional booster dose during pregnancy. CDC and FDA policy should not stand in the way of that decision, but instead should ensure that pregnant people have authorized access to an additional booster dose if they wish to receive one. This, of course, is in addition to continuing to promote and provide access to vaccination for the many, many pregnant people who are not otherwise up to date. Thank you for your consideration, and I look forward to hearing your discussion this afternoon.
Thank you for your comment. Next, we have Dr. Jonathan Vai.
Yes, thank you so much. Dr. Lee and ACIP members, thank you for the opportunity to provide input on this very important subject. I'm a project scientist at the National Center for Atmospheric Research in Boulder, Colorado. I'm also a wildfire survivor. My family lost her home in the Marshall Fire. My 2 children attend elementary school here in Colorado, and there has been a frightful amount of illness at their school this year, including COVID, RSV, flu, and strep. Although no one in my family has tested positive for COVID so far, my son has been sick for weeks, and we worry he could be suffering from post-viral syndrome. I've learned that resilience is vital and that health cannot be taken for granted. I had Moderna for my first 3 vaccinations. After my second shot, I experienced a strong reaction, which included fever, malaise, heart palpitations, and chest pain. My first booster was only somewhat better. It was miserable to have to miss a day of work each time I got vaccinated. Last fall, I was due for my second booster, so I decided to try Novavax. The difference was night and day. The only side effects I experienced were a sore arm, a slight tingle in my scalp, and feeling a little tired in the evening. I was able to work the next day, and for me, Novavax was a game changer. From everything I've heard, I understand that Novavax's monovalent vaccine has effectiveness on par with the bivalent vaccines. Recent real-world data shows that the mRNA protection starts strong and begins fading as early as 4 months. In contrast, Novavax offers durable, lasting protection and excellent protection against severe disease with fewer side effects. Also, many people suffering long COVID have reported that Novavax improved their symptoms. The weight of evidence that we have in hand shows that Novavax is an effective and safe vaccine. Therefore, it is inexplicable why the current guidelines make it nearly impossible for Americans to get Novavax as a second booster. I've not seen any scientific justification that supports this restriction. I'm asking for 4 changes to vaccine immunization practice today. Number 1, please allow all age groups to get vaccinated more than once per year, if desired. Number 2, please speed up the timeline for kids under 12 to be able to get Novavax. I would like my kids to get it. Number 3, allow kids to get their booster a full month before the school year starts. And number 4, please change the guidelines to allow people to get Novavax without regard to their previous vaccination history. We won't achieve full vaccine equity until all Americans have the freedom to choose the vaccine that is best for them. Once we achieve this, I believe that we will see improved uptake of boosters. This will move the needle towards stopping transmission chains and finally ending this pandemic. Thank you very much.
Thank you for your comment. Next, we have Ms. Gwendolyn Cull.
Thank you. My name is Gwendolyn Cull. I'm an attorney and a contributing author for Brownstone Institute. I'm here today to speak about the policy requiring COVID-19 vaccination for foreign travelers to the United States And for those of you who might not be aware, the CDC has an amended order mandating that all travelers, non-citizen, non-immigrants to the United States be vaccinated before boarding an airplane. If this policy were truly for preventing disease, shouldn't we instead mandate testing? This policy has failed at its purpose and is costing thousands precious time with their family members and the US economy billions in revenue. As of August 19th, 2022, the CDC published policies should not differentiate by a person's vaccination status because of breakthrough infections. Yet this policy continues, leading those of us harmed by it to question why. Vindictive punishment for the exercise of medical autonomy or religion. The CDC has a duty to the American public and the US Constitution to rescind the policy, regardless of President Biden's proclamation, because it is unconstitutional. It is an unlawful delegation under Title III since Director Walensky was not appointed through Senate confirmation. It is not rationally related to the purpose of disease prevention since vaccines do not prevent the disease, and it further causes families to be separated. It oversteps authority vested by Congress under the Administrative Procedures Act by creating additional requirements for entry into the United States than are actually legislated under Title VIII, Section 1182A, which only requires proof of vaccination against vaccine preventable diseases prior to entry. Even if the vaccine did prevent disease, the policy is still ineffective because it doesn't apply to Americans who can travel nearly anywhere in the globe unvaccinated, free to transmit the disease. In reality, the policy fails because the vaccines do not prevent disease, and it allows people with active COVID infections to fly to the US so long as they present proof of vaccination. As a result of this policy, binational families have been kept apart, some for more than 3 years. Unvaccinated visa holders living in the United States have been trapped here for fear they will be denied re-entry and lose their jobs or education. Tourists choose non-US destinations. The vaccine is now also senselessly on the immigration schedule for adults and children, again violating 1182A and the PrEP Act. Travel reciprocity is not maintained with other nations, and the US lost nearly $100 billion between lost tourism revenue and the cost of enforcement in the last year alone. Stop wasting resources and taxpayer dollars on this moot and unlawful policy that's causing real harm to innocent, healthy people while not preventing transmission. Rescind the amended order implementing Proclamation 10294. Thank you.
Thank you for your comment. And I want to thank all of our public comment speakers today, as well as those who take the time to submit written public comments via the CDC docket. We are now moving on to the next section, which really is just open for committee discussion of any of the items that were discussed earlier today. So I'd like to ask my committee members if they would like to raise their hands and ask any clarifying questions or have any comments. Thank you, Dr. Lair.
Yes, following up on the public speaker, she did raise a point about pregnant women possibly doing it under some kind of shared decision-making, being able to get a booster if they wanted. That, I'm curious to see whether the FDA or the CDC subcommittee or work group had any thoughts on that, or if they discussed that. Thank you.
Thanks, Dr. Lair. I will say we have a upcoming work group call focused specifically on this, and hope to bring this to an upcoming ACIP meeting. That was true when I said it in February, and apologies that this was an emergency meeting that was added, but that is still on the plan to review additional data and continue additional discussions. At this time, additional doses specifically related to pregnancy aren't authorized, but we look forward to continuing to review data and discussing. Thanks.
Thank you, Ms. McNally.
Thank you. I just wanted to ask two questions. One is about the timing of the communication materials for the general public. And two is just confirming my understanding that the CICP will still be the place for people with any alleged injuries to file claims. Thank you.
Dr. Oliver, did you want to take the first one?
Yeah, I'm happy to take the first one real fast. The answer is we will work on getting this material updated as quickly as possible. I think today has continued to emphasize that they're considerable changes that need to be made both to the interim clinical consideration as well as a variety of clinical education materials that'll be posted. And so we'll work with colleagues across CDC to get them updated as soon as possible. I will acknowledge that this may not be kind of instantaneous with the ACIP or CDC director signing off. So give us a little bit of time, but I promise we'll work on having it updated as soon as possible.
Thanks, Dr. Alden.
And thank you. And Dr. Grimes, are you able to comment on CICP?
Sure. At the current time, the Countermeasures Injury Compensation Program covers alleged injuries from countermeasures that were deployed in response to a pandemic, epidemic, or security threat. So as you all know, COVID-19 vaccines meet the criteria for a countermeasure for a pandemic threat. And there's currently an active PrEP Act declaration, as was spoken to previously. We continue to be the program in which injuries can be claimed for and compensated from. Thank you.
Thank you, Dr. Grimes. Dr. Talbot.
Yes, this is, we've been mentioning other groups, and I think this is another group. We have healthcare workers that work in wards where they're high-risk patients or in clinics where high-risk patients are seen. And we know that all of transmission is not stopped with vaccination, but we do know that you're less likely to transmit. And the closer in time that you've had your last vaccine actually has some impact on that. So it would be an interesting, or it should be considered adding these healthcare workers as a possible second booster, even if they're not immunocompromised or not over 65, because they may work with those populations. And it may be one of the many ways that we try to reduce the risk of transmission. Not completely, but just one of the many steps that we do.
Thank you. I don't know if Ms. Mary Beth Hans is able to get online. If she is, then that would be wonderful. I do want to just comment that there still is a CMS requirement for healthcare personnel vaccination for the primary series and a recommendation for the booster dose. But just want to clarify, Dr. Oliver, if there's any discussions or Dr. Daly around healthcare personnel.
Yeah, so at this time, I think, we've explained the current authorizations for additional doses, and so don't necessarily anticipate that that those will change right now. But we continue to, I think, encourage healthcare providers if they've not had. I'll note that only about 16% of the population has had a single bivalent dose, so would continue to encourage that people get that bivalent booster if they've not previously, and then we'll absolutely continue to review additional data and happy to discuss both at ACIP and then with FDA colleagues about additional populations. Thanks.
And this is Mary Beth Hans, and I would just say that CMS is looking into this with these changes in recommendations, and we'll be working with CDC. But as of right now, we don't have any updates. We're looking into it.
Thank you, Ms. Hans. Dr. Sanchez.
Yes, thank you. I just, with these new recommendations and what is actually up to date, I think it's, it sounds like the wording will be that up to date now means having received a bivalent booster. And I just caution because that will bring a lot of other associated issues regarding vaccination. And it's not just, as Dr. Talbot mentioned, in the healthcare setting, but also in travel and other places as well. So I would just I think it'd be clear on what you mean by up to date, because that really does carry a lot of weight. Thank you.
Dr.
Thank you,
Santos,
Dr.
we're happy to kind of
Sanchez.
clarify. I think for right now, actually, the definition that's on the website says to get the most recent booster recommended for you by CDC. So I think the fact that we include having this most recent booster as a part of the up-to-date definition is actually not a change right now. There's additional, I think, clarity to the up-to-date definition that I think the second booster is not required to be up to date, and some additional kind of guidance on what that means in young children. But the kind of overall framework of having the most recent booster for you, that's not changing. And I'll see if Dr. Twentyman may have something else to add since she had that in her slides. Thanks.
Thanks so much, Dr. Oliver, and thanks for the question. I'll add only that for those people who are unable or choose not to get a bivalent mRNA vaccine, they will be up to date if they receive the Novavax COVID-19 vaccine doses approved for their age group. Thanks.
Thank you. Dr. Saneas.
Thank you. I am a MedPeds provider who sees both children and adults in a busy practice and vaccinate patients. So while I agree that the recommendations are much simpler for patients 6 and older, it's still very confusing for those under the age of 6. So what I wanted to know is what other supports or materials is CDC developing to support practitioners in making quick and timely decisions in a busy practice as to which formulations and how many doses patients needed, particularly for the young patients, and any considerations for possibly developing an app like the Pneumorex app, which is very helpful for the pneumococcal vaccinations.
Thanks so much for the question. This is Dr. Twentyman. We are developing a breadth of materials to support our vaccine providers. Those include the flowcharts that you may have seen here early today. And through those flowcharts, you can start with a child's broad status and just sort of get narrower until you're at the correct dose. Or you can go to the tables which we are developing. We also showed part of one of our tables here today for young children that start on the left-hand column with their precise COVID-19 vaccination history, and then show you all the options for COVID-19 vaccine doses moving forward. I'll additionally point to tools on our website that already exist. The CDC booster tool allows people to figure out the correct dose for them at this time, and that will be updated in line with these recommendations. And then I'll also just applaud our clinical guidance teams who are out in the field every day with additional materials for providers to support ease of vaccination, ease of getting and staying up to date for everyone. Thanks.
Thank you.
Thank you, Dr. Reese.
Thank you, Dr. Marcy Dries-Mache. Regarding healthcare workers, I would just like to thank the ACIP for making their recommendations for unvaccinated people much simpler, because we've actually had a difficult time bringing on new healthcare workers because of the vaccine requirement from CMS and the fact that frequently they were describing having difficulty finding monovalent vaccine or finding a second dose of monovalent vaccine as the case may be. So having just the one bivalent dose will make hiring much easier. Regarding having 2 dose, the option for 2 doses, I think, again, flexibility is nice. There will be certainly some kind of early adopters who definitely want that second dose before the fall. But overall, given that CMS is not currently requiring a bivalent booster, uptake has been very low. So I think, we're hopefully higher than 15% like the general population, but I think probably closer to 30%. So I think uptake of a second dose would be low, but certainly I think, it would be appreciated by some healthcare personnel.
Thank you. Dr. Daly.
Yeah, thanks so much. I guess I'm going to ask a question that's just sort of rhetorical, and then I'm going to follow it up. But my question is what can we do to fill these gaps? In my mind, gaps, some of which we've talked about today, they cause confusion, and then they also cause some consternation. If you're an individual within one of those gaps. I have a certain circumstance, and then I can't find a recommendation that fits for my circumstance. And then what we're hearing from the FDA is that they can only take action when they have strong scientific evidence to do so. So this is really a comment to primarily the sponsors, which is to say, can we have an explicit conversation about what the gaps are? And then can we do the studies to provide the strong scientific evidence to fill those gaps? And maybe that's a conversation that you have first internally and then you have with the FDA. But I can highlight at least 3 or 4 gaps, and these are ones that are on my mind. I know there's other gaps, but one gap is immunocompromised under the age of 5 who received Pfizer. We talked about that. But there's also another gap around adults with chronic conditions who aren't immunocompromised, and what's the role of a more than once a year booster for them. There's this gap or this problem about what to do with 5-year-olds. And I should think that's one that we could figure out so that we don't have to have a special page just for the 5-year-olds. And is there a way to sort of synthesize so that problem doesn't come up? And then there are other gaps that we've talked about at prior meetings, like, can we have additional data about the safety and effectiveness of providing high-dose influenza vaccine with COVID to adults over the age of 65. I was quite reassured by the safety data for that group, but I think we just need to continue to study that. And again, that needs to be high-quality data so that we continue to feel confident in our recommendations. So this is primarily to the sponsors. Can we have an explicit conversation about what the gaps are and what the scientific data is going to be to fill those gaps? Thank you.
Thank you. I'm happy to invite the sponsors if they'd like to comment now or at a later point, but I do think, Dr. Daly, your questions are spot on. I don't see any hands raised, so I will maybe give our sponsors a moment to just, and Dr. Daly, let me just clarify, was that your rhetorical question or was that your actual question?
Well, my rhetorical, thank you for clarifying. My rhetorical question was sort of what can we do to fill the gaps, but then I sort of then went on to try to describe what are some of the gaps that I see. So you can take it as not rhetorical, I guess. Thank you.
Okay, well, how about this? I'm going to ask our sponsors to, I'll go through a few more questions and then we'll ask our sponsors to come back and hopefully be able to provide a response. And we'll call on all available sponsors. Dr. Long, your question?
Yes, I'm glad you're asking me next because it's related to what Dr. Daly said. Immunologically, there is not a difference between a 4, a 5, and a 6-year-old. There is between a newborn and a 2-month-old and a 2-month-old and a 12-month-old and a 12-month-old and a 2-year-old. But after that, they're at their immunologic peak at 5, 6, and 7 years of age. And so there isn't a reason to have all this unnecessary drama around those ages. So my suggestion would also be, we picked 60 months for most immunizations in children, and pediatricians don't talk about to 4 years of age, because what's 4 years of age? 4 years and 0 days, or 4 years and 364 days. So we really talk, so we kind of established for pneumococcal vaccine, for a pneumococcal susceptibility for invasive disease due to Haemophilus, 60 months is the date. And that's when vaccines are really talked about, and they're to 60 months. So to get these 3 different dates and not being careful about saying whether you're talking through 4 years, to 4 years, to 4 years and 0, to 5 years and 0 days, it's completely unnecessary. So that I would say not only the manufacturers, but the FDA, when somebody is talking to the FDA about what they're studying and what they're going to present, I think we can avoid all of this, which is really, really, really defeating for a pediatrician who's trying to stock the optimal vaccines to decrease the incorrect doses and to decrease inventory as it should be. And there is no immunologic difference between a 4-year-old, a 5-year-old, and a 6-year-old in 0 days. So we shouldn't have different recommendations. That's my spiel.
Thank you, Dr. Long. We'll move on to Dr. Hackle.
Thank you. Dr. Peacock mentioned the commercialization, which is being looked at for the next several months. And the AAP is quite concerned about the impact of commercialization on access to the vaccines. Given that up until now, any VFC provider has been able to access the vaccines at no cost, and yet we still have really dismal rates of completion of the vaccine series in our youngest children. Our fear is that when the vaccines are commercialized, VFC will continue to supply the vaccine for the over 50% of all children who get their vaccines through that program. But for the almost half of children who rely on commercially available purchased vaccines, we see a tremendous problem in the making for pediatric providers. We've heard about an estimated cost of the vaccine of between $100 and $130 per dose. We've heard about a minimum order of 100 doses at a time. And I think recognizing that many pediatric practices operate on razor-thin margins, our fear is that few practices are going to be able to invest $10,000 to $13,000 upfront in purchasing the vaccines, especially because we have no indication how we will be paid for the vaccine or for the administration. If we lose those providers of the COVID vaccine, our impact on the vaccine rates will only get worse. Our access to the vaccine for our pediatric population will only get worse if there are fewer providers willing to undertake provision of the vaccine. So I guess my comment is on behalf of the AAP is to urge that when commercialization is considered, particular attention be paid to the providers who undertake the purchase of the vaccines and the administration of the vaccines, to assure that, to encourage them, to incentivize them to continue to provide the vaccine by assuring that they will be paid adequately for the vaccine and for its administration, both in terms of costs as well as a margin above costs. And to be sure that any vaccines that are not administered because of low confidence and low parental uptake, that any vaccines which are not administered will be able to be returnable for credit. Otherwise, the fear of a financial hit is liable to dissuade many practitioners from continuing to provide the COVID vaccine. And again, the impact on access will be dramatic. Thank you.
Thank you, Dr. Nickel. Dr. Sanchez.
Thank you. No, I just want to echo Dr. Long's and Dr. Daly's comment. I think if we really want to simplify the scheduling for children, which it's still a confusing issue. I think that 6 or older, we have simplified, but less than 6, I don't see the need to break the 4 and 5 issue. Now, I understand that Moderna's and the differences in the Moderna Pfizer, what's been studied. I was just questioning also whether that could be allowed to change that, less than 6 years of age, that to combine the 2 recommendations into one. Would that be allowed under the current FDA guidance?
Dr. Sanchez, I'm happy to, overall kind of provide some thoughts, and then happy to see if FDA has anything else to add. I think we both at CDC and FDA kind of acknowledge that the complexities, particularly around kind of that 4, 5, 6 years, how that varies, that it varies by vaccine, that the dose varies by number of doses received previously is absolutely less than ideal. We're trying to do everything we can to make sure that there's clinical decision support, there's figures, there's education for the situation that we're in right now. It is my understanding that we would not be able to change the age cutoffs right now without things changing in the authorization. So would defer to FDA for that. But I will say I did try to highlight throughout the presentations that I think for the pediatric age group in particular, we're not done. So I think there were steps towards simplicity, and again tried to highlight, I think we've taken big steps for the 6 and over population. We fully acknowledge that there's additional steps that need to be taken for the pediatric age group. We look forward to hopefully being able to take those steps based on solid evidence-based decisions in the coming future. We hope that that's in the next, several months as we kind of think towards fall recommendations. We'll continue to work with manufacturers as well as colleagues at FDA to figure out how we can update this using data, but making it as simple as possible. I will note we talked about, even having lower age cutoffs at the February meeting. So I think there are a variety of options and a variety of data that are being discussed right now. And we look forward to kind of taking those additional steps towards simplification, hopefully later this year. Thanks.
Thank you, Sarah, because I think it is important for the pediatricians, and I'm already getting emails and texts about the complexity still. And I have another comment, if I'm allowed, with respect to pregnancy. I really urge that pregnant women, as we anticipate, to make a recommendation for another booster in the fall is a little bit too late for many women who are pregnant currently. So I think that I would urge certainly a first, if not also a second booster, if it's already been over 6 to 12 months since the last bivalent booster. Thank you.
Thank you. I think at this point, I'd like to call on our manufacturer colleagues. So we'll go to Pfizer first, then Moderna, then Novavax. And this relates to some of the questions that were raised during this section. Do we have a colleague from Pfizer who, Dr. Kane, are you still available?
I'm on. It's Charu Sabharwal. Can you hear me?
Please go ahead.
Thanks, Dr. Lee. We very much appreciate the question and would definitely like to work with the FDA to understand the additional data that is required to fill these gaps. So we'll be following up with the FDA. Thank you.
Thank you. Do we have a colleague on from Moderna?
Yes. No, this is Rita Das from Moderna. And, I think we similarly are committed to generating all the data and working with FDA. We do have the bivalent vaccine data for primary series in children, which, we had presented at the VRPAC, and I believe the ACIP presented those data as well. And we are certainly open to simplification and harmonization. We also recently completed our immunocompromised study with renal and liver transplant recipients, and we will be, we have compiled those data and we'll be sharing just in reference to the prominent immunocompromised conversation. So thank you very much.
Thank you, Dr. Das. Dr. Mallory?
Thanks so much. So we are at Novavax broadening our label. Right now, we're submitting data to the FDA around adolescent boosting so that we can have an indication there. We are also will be moving forward to submit data for subsequent boosts in adults beyond the first boost. We do have an ongoing study in younger children to expand into those age groups, and we hope to be moving into the very youngest age group, 6 months to 2-year-olds, in around the May timeframe. So we do recognize that there's a benefit to a broader indication, and we are certainly working hard to gather data to expand our label to that end. Thank you.
Thank you to our colleagues for those comments. Are there any additional questions people would like to raise? And, just want to recognize that we all recognize this is a work in progress. And the goal really is to try and simplify things over time, to be able to help communicate with our provider community and our patients and families, what vaccine is right for them, when do they need it, how often should they get it. So we appreciate how much effort is going into this. I just also have to acknowledge that, two things. One is that it is a real challenge when to create these broad scale recommendations or authorizations to cover every scenario. It's almost like we're trying to do precision public health in a very meaningful way, and we do need to get there, but it is a challenge on implementation and communication. So just want to acknowledge that our CDC colleagues and our FDA colleagues have been really wonderful about trying to get us to that place that we want to get to together. But as with everything, it will be phases, and it will be evolution over time. In the other, just sort of prominent point I wanted to make is that it's this context now that we have is very different from the context in 2020, when the entire population was highly vulnerable. We still have pockets of vulnerability that I think are really important for us to continue to shine a light on, address, make sure we're continuing to think about optimal protection for those who are at the highest risk, as well as vaccine equity. But have to acknowledge that we are now in this era of a different level of population immunity, either due to vaccine infection or hybrid immunity. With the exception being our youngest of children, who really are being born in every year and continue to remain probably the least protected among all of us. So, appreciate the efforts by both FDA and CDC to start to help us develop tools for assessing, personalized recommendations, as well as the communication we need to communicate effectively with the population. Recognize again how hard this is for everybody, but that tremendous efforts are going in to try and support our provider community and our patients and our families to ensure that we are being able to deliver the best possible recommendations for everyone in the US population. Any other comments, questions? I don't see any additional hands raised, so I will ask Dr. Wharton if there are any additional items we need to address before we move towards adjourning the meeting.
Thank you, Dr. Lee. No, I think we've completed today's agenda. I do just want to thank the committee for their really thoughtful discussion, as well as all the liaison representatives who asked questions, and also thank the CDC team who put this together. I do think this is an important milestone in the evolution of the program. We're not yet completely across the finish line in terms of the simple program we would like to have, but we're definitely moving closer, and I am really grateful for the committee's engagement today. Thank you.
Thank you, Dr. Wharton. Are there any objections to adjourning today's meeting? I see no objections. So today's ACIP meeting is now officially adjourned. Thank you everyone for attending, and thank you everyone who presented today and for the questions and comments. We really appreciate both the public transparency around some of the complex evolution of decisions that have happened over time, and again, appreciate that everyone's willing to come and share this information with the public. Hope everyone has a great day. Thank you.